What we'll do is we'll give all 4 talks, and then we'll have Q&A afterwards. So the next speaker is Chris Rich. He is an instructor in the nephrology section at the University of Utah, and he will be speaking about acute kidney injury, previously known as acute renal failure.
Well, thank you for the introduction, and thank you for asking me to come and speak to you all today. Despite what these graphics show, we're not going to be talking about traumatic kidney injury, but in fact, as Dr. Snekian pointed out, this is the entity formerly known as acute renal failure. If I can figure out how to work this. So nothing to disclose. Despite I think my talk is titled Evaluation and Treatment of Acute Renal Failure, but we're going to take a slightly different approach. We'll begin talking about the epidemiology of AKI. I'll spend a bit of time on the different etiologies we're seeing now and ways to go about preventing these forms of AKI. We'll talk a bit about treatment, and then we'll end with a brief discussion of some of the future directions the field is going in. So this is data over the last 25 years, starting in 1980 and ending in 2005, showing the rate of hospitalization for kidney disease. This top line is the hospitalization rate for kidney disease in general. This dark blue line here is the hospitalization rate for acute kidney injury, which seems to be dramatically increasing. Much of this is driven by the older patients. So here we have patients over the age of 65, and on the top line, patients over the age of 75. So why should we be so concerned about that? Well, there are a number of reasons. First of all, patients who develop acute renal failure, either at the time of hospital admission or during their hospitalization, are at increased risk for dying during that hospitalization. This is a retrospective look at about 20,000 patients who were hospitalized over, I think, about a 3-year period. Patients who did not have AKI during that hospitalization had about a 4% in-hospital mortality rate. Those who suffered ATN, or acute kidney injury, had a 30% hospital mortality rate. And then there's these folks, this TA group, or transient azotemia. These are the patients who bump their creatinine, as the expression goes. So patients who creatinine increased by some amount, and within 72 hours or within 3 days, it's returned back to its baseline value. We say, oh, that's probably not a big deal. Well, with a 15% or roughly 3.5-fold increase in mortality, it does seem to be fairly important we recognize this. And the good news is that if you don't die in the hospital, you're at an increased risk of developing end-stage renal disease over the long term. So here are the patients who, without AKI, and following them out for a period of about 3 years here. If you do have AKI, look at your rate of ESRD. So what's driving this? Well, I think it's probably that these patients are not completely recovering from their episode of AKI that happens in the hospital. We're damaging a bunch of nephrons. Some of them are coming back, but not all of them are coming back. So you have some underlying chronic kidney disease. And that's suggested by this data, showing that if you have underlying CKD, here's your risk of ESRD. If you have an episode of AKI, it's about the same. If you have underlying CKD, already have some damage, then have an acute insult, your risk of ESRD is significantly higher. So if you survive your hospitalization with your AKI, you don't end up on dialysis. The other bad news is that you're at increased risk for dying in the long term, too. So this is a collection of studies here, which is about 15 here, a meta-analysis of varying etiologies and varying degrees of kidney injury in the hospital. Heart disease, liver transplants, critical illness, lung transplants. And as you can see here, these are patients who survived their hospitalization, about a 3-fold increased risk of death over the long term. Now, many of those patients, as we said before, probably have some residual kidney disease at the time of discharge. So if we correct for that and take these patients, here are the patients who didn't have AKI, and if we take all the patients who had AKI and then correct for their chronic kidney disease that they now have, you can see they still have an increased rate of dying. So to summarize, we're seeing an increased frequency of AKI in the hospital. It's mostly driven by the elderly population, over 75 and somewhat over age 65 as well. The patients who have AKI in the hospital are at increased risk of dying in the hospital, even those with just bumped their creatinine. That the recovery is often incomplete, and that sadly we probably aren't picking up on that because, I guess we learned last talk, measuring GFR at a level above 60, we're just not very good at measuring it. So it goes unnoticed, and we're seeing it progress. And then over the long term, these patients do have increased risk of mortality. CKD with association with cardiovascular disease is a big reason for that. Briefly, we are going to talk about evaluation today. Sadly, there is not a whole lot new to report over the past couple of years. What we all learned in medical school and is about what we're in nurse practitioner school and PA school is what we're doing today. Breaking it down to post-obstructive causes, ruling out obstruction with ultrasounds, looking for a pre-renal cause, volume depletion. One comment here, we are seeing a lot more of this, it seems like, this decreased effective arterial pressure. So these are your patients with heart failure mostly, and what's now become known as the Cardiorenal Syndrome. A patient that comes in, impaired systolic function, maybe impaired diastolic function, severe volume overload, creatinine is 1.3, you give them diuretics, creatinine continues to rise. These patients do poorly. We're seeing it a lot. Difficult to manage. In terms of diagnosing it, fractional excretion of sodium, pretty good test. Been around for a long time, does seem to be pretty good. This has been validated in a couple of studies. A couple of caveats to it that I would put out there. Times when it's not so useful is when your patient comes in who has underlying kidney disease and you're trying to differentiate between a pre-renal azotemia and an ATN on top of that. Their kidneys can't concentrate urine the way that a normal kidney should, so this test may not be quite as helpful. A couple of other caveats where your patients with actually intrinsic renal disease are going to have a low fractional excretion of sodium would be those patients who have a pigment nephropathy, so myoglobin or rhabdomyolysis or hemolysis tends to cause constriction of the afferent arteriole and give you a low fractional excretion of sodium. Those with an acute glomerulonephritis, and those with contrast nephropathy. The intrinsic causes of renal failure, it's too numerous to list. At least getting a urinalysis looking for hematuria or proteinuria, I think it's a good start to that. So now let's talk about several of the common etiologies we see and strategies for preventing these etiologies and for treating them too, actually. We'll start with contrast-induced nephropathy. Difficult to say how common it is because the risk for it is quite variable depending on the patient population you're looking at, how you're defining contrast nephropathy, what type of studies they're undergoing, and multiple other factors. So a catch-all in various studies, it can be anywhere from less than 5% of the patients to more than 30% of the patients. The risk does seem to be driven by the type of study they're undergoing. So those that are getting intravenous contrast on the lower end of risk. Those undergoing coronary angiograms, at higher risk, and those undergoing non-coronary angiograms, so renal angiograms, aortograms, seem to be at the highest risk for this. There are some patient-specific risk factors, which are pretty well established. These include diabetes and chronic kidney disease, probably the two best predictors. And then any kind of renal hypoperfusion, including heart failure, puts patients at risk. That would also include patients who have volume depletion, those perhaps taking ACE inhibitors or non-steroidal anti-inflammatory agents. Not surprisingly, like other forms of acute kidney injury, those patients who do develop contrast-induced nephropathy do have an increased risk of mortality. You can see it develops pretty quickly and stays consistent over the long term, up to 3 years out. So let's talk about a couple ways of reducing that risk. The first question is, what type of contrast agent do we want to look at using? The so-called high osmolar contrast agents have largely now been replaced by the low osmolar contrast agents. Study here done several years ago compared it, and it seems that at least in patients with diabetes and chronic kidney disease, the risk of contrast nephropathy is lower in folks given the low osmolar contrast agents. Now, 600, 800 milliosmoles per kilogram certainly doesn't seem low compared to a serum osmolality of roughly 290 or 300 milliosmoles per kilogram. So there's now a single agent available called iodixonol, which is isoosmolar, has an osmolality of about 290 milliosmoles per kilogram. One of the first studies compared iodixonol to a low osmolar agent, iohexol, and did suggest a benefit. However, since then, there have been a number of more studies. There's a meta-analysis of about 15 studies here showing that perhaps this side favoring iodixonol, the isoosmolar agent, this side favoring the low osmolar agents. And you can see there's a suggestion that perhaps the isoosmolar agent is a bit safer. However, when you tease this out a bit, this graph compares iodixonol to iohexol, and you can see that there does seem to be a bit of a benefit to the... Losing my pointer here. Lost my pointer here. To iodixonol on the left. On the right side, if we remove the studies that included iohexol, and so we have iodixonol compared to other low osmolar contrast agents, doesn't seem to be much difference. So you can say the jury is still out, but it doesn't seem at this point like there's a real compelling reason to use iodixonol at this point. Do you get a way to fix that? Oh, got it. So what about N-acetylcysteine, or NAC? Well, first study was published about 10 years ago, and in 80 patients who were given, 40 of whom got N-acetylcysteine before getting intravenous contrast, half of them didn't. You can see there was a significant reduction, 2% versus 21% who developed contrast nephropathy. Since this study was published, there have been innumerable further studies. There have been more than 30 further randomized controlled trials, more than 10 meta-analyses, and then analyses of meta-analyses. So that pretty much suggests that we still aren't convinced that N-acetylcysteine is of great benefit. Here you can see a collection of studies, most of which sort of straddle the confidence interval here, but there is some suggestion here anyway that perhaps N-acetylcysteine is of benefit. Test of heterogeneity here, though, 55% showing significantly different outcomes between these studies. Same thing here, another meta-analysis of N-acetylcysteine, kind of straddling the line of one there. So remains sort of unproven whether N-acetylcysteine is of great benefit or not. Sodium bicarbonate. First big study published in 2004 suggested a pretty strong benefit. You can see here that one patient in the sodium bicarb group versus about 10 patients in the sodium chloride group developed contrast nephropathy. Up to this point, it has been fairly well established that volume resuscitation or administration of at least intravenous saline prior to contrast is a benefit. But with a sodium bicarbonate acting as an antioxidant agent could perhaps make this better. Seems to be borne out by this initial study. Like N-acetylcysteine, there have been a number of further trials. Taking 7 of the high-quality trials, there have been more than 10 so far. Taking 7 of the high-quality studies that have been done thus far, suggestion of a benefit to intravenous sodium bicarbonate administered before or then after contrast. And same result here, another meta-analysis of sodium bicarb, again suggesting a benefit. Iodinated contrast is removed by dialysis. So one would suspect that if we are able to dialyze folks immediately after that contrast load, remove that intravenous contrast, perhaps we could spare some of the kidney damage that goes on. Well, though that would intuitively make sense, it has not been thus far borne out in the studies. There have been several so far, and here are 7 of them. And you can actually see that in many of them, there seems to be an increased risk of harm. So here, this side would favor doing dialysis after contrast administration. This side would suggest that it was harmful. So why would it be harmful? Well, a couple of theories there. The filter perhaps is not so biocompatible. We get some complement activation, kidney injury from the dialysis itself. These patients may be ill. They're at risk of hypotension. Dialysis, as you I'm sure are aware, can lower blood pressures acutely, causing further kidney injury. One study here did seem to suggest a benefit, and this is a study where patients were put on continuous renal replacement therapy before the procedure and then immediately after the procedure as well. Well, the problem here is what we're doing is we're following serum creatinine values. And so if you get dialysis before the procedure, of course your serum creatinine is going to come down. And after you stop it, it's going to sort of rise again. But we don't have any long-term data from this, so hard to say that this is really any worse than this, because this is all just a product of dialysis. There is one study that has been recently that does suggest the possibility of a benefit. These are patients who all had serum creatinines over 3.5, so fairly advanced kidney disease. They're all coming in to have coronary angiograms done. Half the group was randomized to prophylactic dialysis. The other half, not so much. So they had a temporary femoral dialysis catheter placed, had their coronary angiogram, and then as soon as immediately possible after that, received about 3 hours of sort of a low rate of dialysis. The group that had the prophylactic dialysis, only about 5% of those patients required acute dialysis after the procedures, compared to 35% of the folks who didn't have that prophylactic dialysis. And about 15% of the patients who did not have prophylactic dialysis ended up on permanent dialysis. A couple of problems here, though, to this study. Bit few strange rules that sort of mandated when acute dialysis had to be initiated. In other words, if the patient was oliguric for 48 hours after the procedure, they're required to be started on acute dialysis, which doesn't necessarily fit with clinical practice. Once these patients go on dialysis, on the part of the nephrologist, there's probably a bit of a hesitancy to stop dialysis when you have these patients who already have fairly advanced disease, and we've got them on dialysis now. We know their chances of recovery is slow, and how long, if we stop dialysis, how long would they remain off of dialysis? So difficult to interpret this study as well. So to summarize, our low osmolar contrast agents. Yes, I have a question. It's an excellent question, and I think what we're referring to there is in our end-stage renal disease patients who have arteriovenous fistulas created prior to the indication for dialysis, and that mortality is more of a long-term phenomenon rather than a short-term phenomenon. So these are patients who presumably didn't have access done, who GFRs were creatinine over 3.5, GFR was probably in the 20 range, so they may not have needed to have an AV fistula created at that point. So our low osmolar contrast agents are probably just about as safe as the isoosmolar agents. N-acetylcysteine, the jury is still out, but given that it is safe, it's cheap, may not be so palatable to our patients, but that's an aside. I think it's worth using. 600 to 1,200 milligrams twice before the contrast and after the contrast it's administered. Volume expansion, definitely effective. As I said before, saline used to be the agent of choice. Now I think most folks are in general agreement that sodium bicarbonate may offer a slight advantage. This is the protocol that was done in the first study. 3 ampules of sodium bicarbonate in a liter of sterile water, infused at a rate of 3 milliliters per kilogram per hour over 1 hour prior to the study, and then 1 milliliter per kilogram per hour for 6 to 12 hours after the study. Whether isotonic saline or half normal saline is sort of a second-line agent remains unclear. I think isotonic saline probably makes the most sense. To this point, dialysis for removal of contrast as a means to prevent contrast-induced nephropathy, probably not worth doing. That last study would suggest maybe in patients with very advanced chronic kidney disease, but again, remains unclear. I recently had a patient actually sort of in that same position, elected not to dialyze them after contrast was administered. Age was over 85, baseline low blood pressure, diabetes, high risk for intradialytic hypotension and dropping his blood pressure, and so the chance of doing more harm than good, I think, was there. So again, it comes down to an individualized decision. The Paternal Syndrome. The International Ascites Club, which I think is a great name for a group of physicians, recently revised their criteria for diagnosing HRS or Paternal Syndrome. Most of these are the same, cirrhosis with ascites, serum creatinine over 1.5. One change here is that intravenous albumin is the replacement fluid of choice rather than saline at this point. Used to say they, stop diuretics, give saline for 2 hours or so, or 2 days. Now, intravenous albumin at 1 gram per kilogram per day for 2 to 3 days is what's recommended. It used to be that the patient had to have no ongoing infection. As you know, many patients have spontaneous bacterial peritonitis, they have urinary tract infection. So long as the infection is being treated, they're not in shock, we can go ahead and make the diagnosis of Paternal Syndrome. One removal is that urine sodium of less than 5. I think it still is very helpful diagnostically, but it's no longer required to establish the diagnosis of a Paternal Syndrome. Now, these are established mostly for research purposes, but I think still helpful in sort of seeing these patients. So what about treating a Paternal Syndrome? Well, liver transplant is the treatment of choice. Those who develop Paternal Syndrome have a very high mortality rate in the short term. The physiology of it is thought to be that these patients have splanchnic vasodilation, so blood sort of pools in the splanchnic vessels. We have vasodilation then vasoconstriction outside the splanchnic vasculature, especially within the kidneys themselves. So we basically have impaired renal perfusion. So they tend to have advanced liver disease, hyperbilirubinemia, coagulopathy, low blood pressure. So the thought is here that if we can shunt blood out of the splanchnic vasculature and back into the systemic circulation, we can increase renal perfusion and improve the chances of renal recovery. Teropressin is a vasopressin agonist that is unfortunately not currently available in the United States, but is widely used in Europe. In this study here, patients with hepatorenal syndrome were administered intravenous albumin and teropressin. And at 2 weeks, you can see that the rate of recovery from hepatorenal syndrome was about threefold better in the group that got teropressin. There have been a number of studies prior to this. This is the largest randomized controlled trial done to date. I think about 115 patients in it. So still small, but definitely suggestive of a benefit. Those who had their hepatorenal syndrome reversed had an improvement in transplant-free outcome of survival. So patients who did not have the reversed versus those who had their HRS reversed, so recovered their renal function. Unfortunately, those who got teropressin versus those who did not get teropressin, the mortality rate was about the same. So whether the drug did it or just recovery did it, hard to say. And that's consistent with the 3 previous studies that have looked at teropressin and albumin. When we pull those 3 studies together, though, a meta-analysis does seem to suggest that there is perhaps a mortality or survival advantage to teropressin and albumin. Like I said, teropressin is not currently available in the United States. There have been some small studies where they've used levofed or norepinephrine infusions with results somewhat similar to the teropressin results. Needing an ICU to undergo that kind of therapy. So a lot of times now, octreotide and midodrine seem to be the treatments of choice in the United States. This is driven largely from a single study, a retrospective study, which showed an improvement in reduction in recovery of renal function here and in survival here in the group that got octreotide and midodrine. But again, a small retrospective study. A disease that's kind of come up in the past few years is acute phosphate nephropathy. You can see this graphic's obtained from some attorneys experienced in drug product liability, as many of our fancy graphics do. It seems to occur when patients get a large load of phosphate. These OSPs, or oral sodium phosphate preparations, are given as a bowel cleansing agent prior to undergoing colonoscopies. They're tablets. They are prescriptions now. There have been more than 40 biopsy-proven cases of this thus far. There's a lot of colonoscopies that go on. There's a lot of bowel preps that go on. With this really small number of cases, it's been difficult in epidemiologic studies to show that there is definitely an increased risk of AKI in the folks who get these oral sodium phosphate preparations as opposed to those who get the ethylene glycol preparations. So who is at risk for this? Well, it seems like it is the folks who already have underlying kidney disease, especially those with chronic kidney disease. I would also throw in there patients who have acute kidney injury, those who have volume depletion, those who are in shock, those who are taking nonsteroidal anti-inflammatory agents, which impair renal perfusion, those on ACE inhibitors, which can impair renal perfusion. So these are the patients who I think we definitely want to avoid giving these oral sodium phosphate preparations to, especially since we have effective alternatives. Treatment. Well, this is really where we're at in the treatment of acute kidney injury. Really haven't come very far recently. Gently hitting the kidneys will help to shake out sediment. We don't have any real effective pharmacologic treatments for ATN or AKI that we see in the hospital. Supportive care with dialysis is kind of where we're at. It is a life-saving therapy. There are a couple things we do know about dialysis. What we do know is the dose of dialysis that's a benefit here. There have been a couple of studies over the past 10 years, smaller studies comparing more to less dialysis, both with the standard intermittent dialysis given once a day or 3 times a week in the hospital, or so-called CRT or continuous renal replacement therapy, the continuous dialysis, given at higher or lower doses. And there seemed to be a suggestion that higher doses improved outcomes. And this study might even, this advertisement in some of our nephrology journals may even suggest that CRT can help to save a lot of patients. Well, here's the data this study refers to. Turns out that the increased dose of dialysis with CRT, by this line, compared to the low dose of CRT, we get similar outcomes. So it helps us in dosing our dialysis. Same thing here in another large study where we combined your standard intermittent dialysis with continuous renal replacement therapy, or slow continuous dialysis, and compared the high dose versus the low dose, and again had similar outcomes. There's also been a number of studies that have compared intermittent dialysis with continuous renal replacement therapy, or CRT, the continuous dialysis. Those studies have thus far failed to show either a survival benefit or a renal recovery benefit in the patients undergoing either therapy. That said, there certainly are a number of patients who, because of hemodynamics in the ICU, in shock, they aren't going to tolerate the fluid shifts with intermittent dialysis, and they may require CRT. So just briefly touch on some of the future directions that we can see here in the field of AKI. Serum creatinine as a marker of acute renal failure, or AKI, is not very good. As we heard in our last talk here, the patient who has a GFR of 0 for the past day, his creatinine may increase from 1 to 2 over 24 hours, but his GFR is 0, not 40 as our MDRD equation may suggest. So there are some new biomarkers out there which we hope are sort of going to be equivalent to the cardiac troponins. These are urine tests which turn positive within hours of the kidney injury happening. They're in research phases now. They're send-out labs, so you get the urine sample, send it off to the lab, and 3 days later now you get your result. So clinically not really useful right now, but we're hopeful that in the future they will be more useful. However, they'll only be more useful if we can find more effective treatments for AKI. There have been a number of therapies that have been effective in animal models, and then when we bring those over to humans, they don't seem to be effective. And one of the thoughts is that we're not catching the ATN or the AKI soon enough. And if we can have these tests, we can catch AKI right when they hit the door and employ these strategies, perhaps we will find effective pharmacologic therapies. And just to push, one of the things we're doing right now is mesenchymal stem cell infusions, where we're actually infusing stem cells front into patients at the time of cardiac surgery, hoping that this will reduce their risk of kidney injury after bypass surgery. And if it's helpful here, perhaps it'd be helpful for other kinds of acute kidney injury. So thank you for your time.
Will be questions afterwards. They're getting younger and younger. Either I'm getting older and older. Chris seems so young.